Hi, good morning, everybody. Welcome to the first scientific press briefing of the IASLC World Conference on Lung Cancer 2023. Most of us probably remember 3 years ago, we were supposed to have this meeting, but we were at home under lockdown. So it really is great to be here in Singapore. I think we can all agree that these in-person meetings add a lot and really bring us all together for the ability for events like this to ask questions and to hear about the great research that IASLC has supported. And today's press briefing is going to cover a lot of territory, from the results of a phase 3 study on an intriguing therapy called Benmelstobar to 2 combined presentations on the stigmatization of patients coping with lung cancer. These are critically important things for our patients, and I think newsworthy topics. We'll hear also a presentation from a young up-and-coming researcher who's been studying the role of exhaled breath can play as a screening tool for lung cancer and mesothelioma. In addition, we'll hear an update on the Crystal-1 study with Dr. Shirish Gadgeel, and Dr. Solange Peters will cap off the briefing with a report on Checkmate 227 with new quality of life data that will also be of value to clinicians and patients alike. Finally, but perhaps most importantly, our patient advocate, Janet Daly is going to wrap this up. Janet Freeman Daly will provide a summary of what these presentations mean to patients. And that's really something that we as a group have stuck to, this idea of bringing the science to the patients and getting the patient's perspective on what we're doing well or what we're doing wrong, Janet. And I'm proud to say that IASLC has been a leader in including patient advocates in our conferences and press briefings, and we're fortunate to have Janet with us today. So let's get started. Our first presentation, I think, will be surprising. It's a drug you probably haven't heard much about, but the title is Benmelstobar with Anlotinib plus chemotherapy as first-line therapy for extensive stage small cell lung cancer, a randomized double-blind phase 3 trial. As you all know, small cell is something we've struggled with. We made great strides in targeted therapy, immunotherapy for adenocarcinoma, for non-small cell lung cancer in general, but we're still trying to raise the bar for small cell. And I think that this paper really gets to that. Dr. Cheng is the chief physician, Department of Thoracic Oncology at the Jilin Cancer Hospital in China, and she's the vice president of the China Society of Clinical Oncology. She's participated in hundreds, literally, of studies and trials. She's given oral presentations across the world at all the major meetings, and she's an expert publishing more than 350 scientific articles in leading scientific journals. So she's really an expert in the field. Please welcome Dr. Ying Cheng to discuss the first paper.
Thank you for your introduction. I'm very happy to here for this press conference. Ladies and gentlemen, I'm Ying from Jilin Cancer Hospital, China. I'm grateful to be invited by WCLC committee to report ES-701 results on behalf of our investigators. It's a multi-center randomized double-blind placebo-controlled phase 3 trial to assess the efficacy and safety of Anlotinib in combination with Benmelstobar and chemotherapy for first-line extensive stage small cell lung cancer. As we know, small cell lung cancer recalcitrant malignancy. Immunochemotherapy shows 2 to 4 months overall survival benefits in extensive stage small cell lung cancer. However, long-term survival improvement remains unmet. The limited benefit might attribute to the completed microenvironment. Based on the complexity and the heterogeneity of small cell lung cancer microenvironment, we made an advanced design combining a novel developed PD-L1 inhibitor, Benmelstobar, with a small molecule multi-targeted anti-angiogenesis agent, Anlotinib, plus standard chemotherapy to identify efficacy, survival, and safety in extensive stage small cell lung cancer. We can see this is a study design. It's a multi-center randomized control phase 3 study previously untreated, histologically confirmed small cell lung cancer. Patients were randomized 1:1:1 ratio to receive 4 cycles of Benmelstobar plus Anlotinib and EC regimen, placebo plus Anlotinib and EC, or dual placebo and dual followed by Benmelstobar plus Anlotinib, plus placebo and Anlotinib, or dual placebo as maintenance therapy until intolerable toxicity or disease progression. The stratification factor was ECOG 0, brain metastasis, and the liver metastasis. The main endpoints was PFS and overall survival evaluated by independent review committee. This time, we only report data of 4 drugs, Benmelstobar plus Anlotinib and the EC regimen versus control arm, double placebo and EC. It is a patient disposition. 738 patients were randomized, 256 patients in experimental arm and 247 patients in control arm received treatment. 47.6% and 74.8% received subsequent anti-tumor treatment respectively. These baseline features of the 2 arms was very balanced. Here is the dependent review committee evaluated the PFS data from ITT population. As data cutoff in 4 drug arm and control arm, 60% and 80% of patients had PFS events. Median PFS was 6.9 months versus 4.2 months. Hazard ratio was 0.32. P-value was less than 0.001. 12 months PFS rate was 27.9% versus 2.3%. This is the overall survival results. 38.6% versus 54.3% of patients had overall survival events, and the median overall survival was 19.3 months versus 11.9 months in 4 drugs arm and the control group respectively. Hazard ratio was 0.61 and p-value was 0.0002. And 20 months overall survival rate was 41.8% and 24.2% in 2 arms. Subgroup analysis showed that all subgroups had a benefit over survival and PFS from 4 drug treatment. According to independent review committee evaluation, 3 patients in drugs arm obtained complete response. Confirmed objective response was 81.3% versus 66.8%. Duration of response was 5.8 months versus 3.1 months. As a safety profile, the incidence of any grade or grade 3 above TRAE was similar in both arms. More than 10 of common TRAE mentally were hematologic toxicity and liver function change. In conclusion, compared to chemotherapy, our study confirmed 4 drugs therapy significantly improved overall survival and PFS with manageable safety in extensive stage small cell lung cancer. The addition of anti-angiogenesis to basis of immunochemotherapy improved longest PFS and OS in first-line extensive small cell lung cancer so far. Thank you for your attention.
Thanks very much, Dr. Cheng. Unfortunately, Dr. Cheng has to leave to go give her presentation shortly, so I hope everyone can attend. As you all know, seeing separation of survival curves in small cell like that is quite remarkable and something we don't see often in lung cancer. So hopefully the presentation will be robustly discussed and put in the context for everybody, but I encourage you to go to see her presentation if possible. Next, our next presenter offers a unique look at how examining exhaled breath may help us predict treatment response in mesothelioma. This is obviously another difficult disease for us to tackle, but of interest, I think, broadly, prediction of treatment response, but also the breath. We're unique in lung cancer in the lung space that directly connected to the lungs is the real word in the breath. And so many have looked for inhaled or exhaled biomarkers. Dr. Lamote graduated as a Master in Biomedical Sciences in 2011 at Ghent University in Belgium, where he obtained his PhD as well in 2017. He's worked to develop validated breath tests to detect mesothelioma and lung cancer in at-risk patients exposed to asbestos. And this is based upon the analysis of volatiles in breath by using mass spectrometry, sensors, and spectroscopic techniques. And since then, he's continued his work at the University of Antwerp, where he's currently assessing the clinical utility of a breath test and extending his research to study the volatiles in the gut and in the lung microbiome and their use in diagnostic and monitoring biomarkers. Please welcome Dr. Kevin Lamote from the University of Antwerp in Belgium, who will present treatment response in malignant pleural mesothelioma patients can be predicted by exhaled breath analysis.
So thank you for a very nice introduction and for the opportunity to present some of the work here. As mentioned, I will talk a little bit more about pleural mesothelioma. So it's a very fatal cancer with a very low survival rates, which is induced by exposure to historical asbestos fibers or asbestos fibers in the past. Why is it so fatal? It's because it's a very long latency periods between the first exposure to the fibers and the diagnosis of the disease. And treatment options currently are chemotherapy consisting of platinum salts combined with pemetrexed. And recently new, the immuno-oncology and the immune checkpoint inhibition was approved combining ipilimumab with nivolumab, which has really nice results. However, there's a very low disease control rate. So only 20% of the patients, of about 20%, really react to this treatment. So there's a lack in improving and selecting these patients out who will respond to certain treatments or not in order to improve the survival rates. And in that way, we try to identify markers of companion diagnostic biomarkers and exhale breath to do so. Now, exhale breath contains volatile organic compounds, and these arise from the different metabolism and change in metabolism that happens when a mesothelioma is developing after asbestos exposure. So by inhaling asbestos, you induce, for instance, a lot of necrosis, you induce oxidative stress, and this liberates these volatile compounds. And since these volatile, they come into the breath and we can detect them in the exhale breath. Now, what we've done in the past is worked upon how can we use it in that way to diagnose disease, for which we will have a talk later this week at the meeting. But today I'd like to focus on using it to try to see who will not respond to a certain treatment. Why is that? Because in the past, one of the group of Paul Baas also investigated this use using a kind of a sensor. It's an electronic nose which can really smell the compounds in exhale breath. But the downside was that this does not allow to identify the compounds that are present in the breath and thus link it to the pathways that are associated with the type of response. So our goal was to identify these compounds that differ between these profiles and see whether or not responders after treatment can be differentiated from non-responders after treatment, and afterwards if we can use this breath print to predict the response earlier on. So it just was a little bit of a feasibility study. We included 15 patients with pleural mesothelioma, and every 3 months they come for their follow-up, and they get a CT scan and they get a breath sampling. So the CT scan is then scored as, according to the MRISE criteria, as a stable disease or a progressive disease. And we use a technique called multicapillary column ion mobility spectrometry to sample the exhaled breath, according to protocol we have used in the past. We sample alveolar air, and we also sample surrounding air, so the background, to correct for potential confounding factors that arise from the surrounding environment from the clinic. We have identified 106 of the volatiles in all of our patient samples, and we calculated the peak intensity, which is a surrogate for the concentration of these volatiles. And then we did some statistics upon it. So first, we built a discriminative model. So after treatment, we knew who were responders and non-responders to the previous treatment. And we say, okay, we look, can we differentiate between the two? And once that's established, if that is possible, then we can look at the previous measurement and breath sample and see if this can also allow to predict who will be responder or non-responder at the subsequent follow-up. So looking after treatment, we see that most of our groups were nicely matched. Most of our patients contained or getting the chemotherapy. But we could differentiate all of our groups with an acceptable accuracy. We were very happy to see that. After treatment, differentiate between the two. And we have found here 6 of the volatiles, which are listed over here, who were the drivers of the differences between the two groups. Now, after treatment, this was the response. So we looked also, if we apply this model on beforehand and a predictive setting, can we predict response and non-response based on the previous measurements? And we get likely results. So we have a really nice discrimination based on the previous breath sample to differentiate responders to non-responders before the treatment has started. And nice to see also, it was also based upon these 6 volatiles presented over here. So we have seen in this preliminary study that exhaled breath really can be promising in predicting a treatment outcome in mesothelioma patients based upon certain volatiles, which will now will be further validated in a larger population. We will also define the VOC profile for each treatment because most of our patients get now chemotherapy. So it was not powered enough to differentiate between the chemotherapy and then the immunotherapy patients. So we will elaborate more on that. And we try to further identify the volatiles to specific GCMS measurements and link them to the underlying metabolites. So with that, I'd like to thank all of the collaborators and the patients and you for the attention.
Thanks so much for that. I suspect that all the patients on the podium will be thinking very favorably about a breath test to monitor response and prediction. I'm interested to hear Janet's comments at the end. So next, our third abstract is titled Crystal 1, the 2-year follow-up of Adagrasib monotherapy in patients with advanced metastatic KRAS G12C mutated non-small cell lung cancer. And imagine this is a target once thought undruggable, and now we're talking about 2-year follow-up. Dr. Gadgeel is the Associate Director at the Henry Ford Cancer Institute and Chief of the Division of Hematology and Oncology at Henry Ford. He's also Professor of Internal Medicine at Michigan State University. He has a remarkable clinical research experience spanning over 20 years, Associate Editor of many journals, and has been on the faculty at all of our international organizations, and also awarded by the National Cancer Institute the Cancer Clinical Investigator Team Leadership Award in 2012. So few people better qualified. Please, Dr. Gadgeel.
Thank you very much, Dr. Stiles. What we are going to present today are the 2-year follow-up data of Adagrasib monotherapy in patients with metastatic or advanced KRAS G12C mutated non-small cell lung cancer patients. These are results from the Crystal 1 trial. So Adagrasib is a covalent inhibitor of KRAS G12C, And recently it received approval, accelerated approval by the US FDA for the treatment of pre-treated KRAS G12C non-small cell lung cancer patients based on the results of the phase 2 cohort A from KRYSTAL-1 trial. In this cohort, 116 patients were treated with adagrasib at a dose of 600 milligrams BID and had a response rate of 42.9% and a median duration of response of 8.5 months. Today, we're going to present the results of 2-year outcomes of 132 patients enrolled in the phase 1 dose escalation, dose expansion cohorts, as well as the phase 2 cohort A of KRYSTAL-1 trial. Again, all the 132 patients were treated with adagrasib at a dose of 600 milligrams BID, and the median follow-up of this analysis is 26.9 months. The median survival of these 132 patients treated with adagrasib was 14.1 months. The 1-year survival rate was 52.8%, and the 2-year survival rate was 31.3%. The median progression-free survival in this patient population was 6.9 months, with 1-year progression-free survival rate of 35% and 2-year progression-free survival of 13.9%. The overall response rate was 43%, and the median duration of response was 12.4 months. Benefit was also assessed in different subsets. Efficacy was observed in subsets based on presence of co-mutations at baseline in the tumor, and the median survival ranged from 5.7 months among patients with KIP1 co-mutated tumors, and it was 18.7 months among patients with P53 co-mutated tumors. Efficacy was also observed among patients with baseline CNS metastases at a median survival of 14.7 months and a median progression-free survival of 6.9 months. The swimmer's plot represents the duration of therapy among the 55 responders. Dose modification, defined as any dose interruption or any dose reduction, did not appear to impact efficacy with adagrasib, in that 33 of the responding patients who received the drug for more than 1 year and 12 patients who received the drug more than 12 years all required dose modification. In addition, among patients who underwent dose modification, the 2-year survival rate was 32%. No new safety signals were identified with this 2-year follow-up. Importantly, even with the long-term follow-up, none of the 12 patients who started the drug within 30 days of immunotherapy developed grade 3 or greater hepatotoxicity, and only 1 patient discontinued the drug due to grade 3 hepatotoxicity. In addition, among patients who had received the drug for 1 year or longer, none of the patients developed new onset treatment-related AEs after 1 year. Very few patients developed new onset treatment-related AEs after 1 year, and most of these were GI toxicities, fatigue, or elevation in blood serum creatinine levels. So what this 2-year follow-up demonstrates is that in previously treated KRAS G12C mutated non-small cell lung cancer patients, adagrasib demonstrated durable clinical benefit with a median survival of 14.1 months and a 2-year survival of 31%. There were no new safety signals, and the drug appeared to be well tolerated, with particularly in patients who received the drug for more than 1 year, with very few patients experiencing adverse events after 1 year. Dose modification did not appear to impact efficacy with adagrasib, and the 2-year survival among patients who underwent dose modification was 32%. Efficacy was observed in a variety of subsets, including patients with baseline CNS metastases. And the rate of grade 3 toxicity with adagrasib was low. In particular, none of the 12 patients who received the drug within 30 days of receiving checkpoint inhibitor developed grade 3 or greater hepatotoxicity. There's a confirmatory trial, KRYSTAL-12, that is ongoing, comparing adagrasib with docetaxel in pre-treated KRAS G12C mutated non-small cell lung cancer patients. would like to thank the patients and the investigators who participated in the Crystal-1 trial. Thank you very much.
Thanks, Dr. Gadgeel, and hopefully people will be able to make that presentation this afternoon as well. Our next presentation is quite unique, and I think it's particularly appropriate that we talk about it here with members of the press. And it's the idea of what stigmatization does to lung cancer patients and how we perpetuate that stigmatization. The World Conference on Lung Cancer has always made room for non-pharmacologic studies. In the past, our members have presented on air pollution, tobacco stock ownership, and sexual dysfunction among women coping with cancer, to name just a few. And I think we have to realize that our patients are more than their disease, and that cancer can affect virtually all phases of our lives and of our patients' lives. Particularly, it's important about how how patients feel, I think, and how the topic of stigmatization is sometimes passed on inadvertently in the press. Our presenters, Dr. Harrison and Dr. Jill Feldman, I've promoted you. You're such a professional that I've promoted you. And Jill Feldman will discuss two different abstracts, but because they're both important topics on stigmatization and patients coping with cancer, we thought it'd be best to present their findings together. So first, I'll introduce Jill. Jill really has had a 30-year roller coaster ride with lung cancer. And many of you probably know her story, but when she was 13, she lost her father and two grandparents to lung cancer. Then both her mom and aunt died from lung cancer when she was in her 20s. She channeled her grief and anger, and I think anger is an important word for Jill. You know, when I first read this, I said, I don't want to say anger, but I think it's okay to be angry about this, right? And she joined Longevity Foundation and became a patient advocate for IASLC. Because she didn't want her 4 children to go through what she experienced, she went regular CT scans, and we'll hear about CT scans and never smokers in another presentation. Unfortunately, at age 39, she too was diagnosed with lung cancer. So 2 surgeries, targeted therapy, stereotactic radiation therapy later, several medical treatment regimens. She's still alive, and a testament to hope, persistence, and medical and scientific progress. I'll introduce Dr. Nathan Harrison as well from Flinders University in Australia, as they'll speak together. Dr. Harrison's a public health PhD candidate at Flinders University and Flinders Health and Medical Research Institute in Adelaide, Australia. He's focused on lung cancer screening, smoking, and stigma, and he works with a broader research team focused on implementation of lung cancer screening in Australia. He's a senior research officer at the National Center for Education and Training on Addiction in Flinders, where he conducts policy-relevant research on smoking and cancer risk reduction. So let's hear what you have to say. Yep, you are definitely a doctor in my mind. You guys both together?
No, I'm
Okay, so you go first.
so we're separate. All right, so thank you. I really appreciate the opportunity to talk about the IASLC language guide and our study on early adopters of the language guide. I think what's really important in here is there's been so much progress and advancements in research and treatment of lung cancer, but the stigma surrounding lung cancer remains a deadly problem. Whoops. I guess I'll use the arrow. There it is. So there is, what?
There's a clicker up here too.
Oh, clicker, okay. So there is an undeniable blame culture in lung cancer that you just don't see with other cancers. Every other cancer elicits empathy and response such as, I am so sorry, what can I do to help? But for most of us living with lung cancer, the first question we are asked is, did you smoke? Now, those 3 words, which seemingly are innocent and is an innocent question, may appear to be harmless, actually have significant implications and consequences. And Brendon told you a little bit about my story. And the first time I actually experienced stigma was 40 years ago. My dad was diagnosed with lung cancer and died at 41 years old. And I was at a baseball game, and a friend of mine kind of turned to me and said, you're never in a good mood anymore. And I said, well, my dad just died. And she said, well, my mom said it was your dad's fault because he was a smoker. Needless to say that the emotional scars and impact that I experienced at 13 years old stay with me today. And I continued to experience that stigma when my mom and my aunt died when I was in my 20s. And since my own diagnosis, I continued to experience that stigma. Now, I have learned how to handle it, but to really watch my kids go through what I went through is heart-wrenching. So words matter is not just a catchphrase. It's a simple yet profound when talking about lung cancer. There we go. So recognizing the urgency to combat stigma and to promote patient respect and dignity, the IASLC language guide was created. It was a collaborative effort between IASLC, patient advocates, the National Lung Cancer Roundtable Stigma Task Group, and others from different organizations and disciplines. On the left side, you'll see the 4 principles. Now, the guide isn't an exhaustive list of do's and don'ts or rules. It's not meant to call anybody out. Rather, it's meant to call people in to help with raising awareness and promoting inclusion when we talk about lung cancer. And so this guide was approved unanimously by the IASLC board in May of 2021. And so what our study did was we analyzed presentations from World Conference 2022, just one year after the guide was implemented or published, to assess the adoption of non-stigmatizing language within the first year, and also to see if there were any correlations with presenter characteristics. Now, we focused on the term smoker because it was the first word in the list of stigmatizing language in the guide. So we searched for its usage in the slide presentations, and we also explored presenter backgrounds. And when looking at the results, we used 2 different types of analysis yielding consistent data. So we were happy to see that. And we'll talk a little bit more about the data within the oral abstract session. But the highlight is that 177 of 519 slides discuss smoking status. And of those 177, 43% use non-stigmatizing language. We found that non-stigmatizing language was embraced more by PhDs and people in the other category, which included RNs, MS, and patient advocates. But really what the focus and the key here that we want to emphasize is that all groups exhibited positive change, and that where there's not statistical significance in other categories necessarily, you know, I always say statistical significance doesn't automatically equate to clinical significance in, you know, other research. It's the same here. The diversity in the continents, in the specialties shows promise. That is significant, as does seeing a change in how people are talking about lung cancer. And what's really exciting on the left-hand side, the language guide has already had, you know, an impact and made significant inroads within our community, but it's also gained traction outside of the lung cancer community. And one major step was looking at one of the largest tobacco, journals, The Tobacco Control Journal, which recently changed its policy to highlight the importance of non-stigmatizing language, specifically person first and not labeling people by their smoking status. But the greatest impact lies in the influence of the National Comprehensive Cancer Network. NCCN their recent language guidance cites the IASLC language guide. Now, why is this a big deal? Because NCCN serves as one of the primary go-to resources for clinicians and insurance companies in determining patient care pathways. And so having NCCN cite our language guide signifies a significant and pivotal endorsement in the medical community. In other words, it is and it should be a game changer. Now, of course, change comes with challenges and old habits die hard, and we definitely recognize we have a lot of work to be done. We know that language isn't static. Well, neither is the language guide. We are actively working on a second iteration to address some of the known challenges and ensure it remains effective in promoting respect and dignity. And furthermore, we have initiated discussions about a dissemination plan and developing metrics to measure its success on a much larger scale. But the language guide is a crucial step, and we recognize it's not the only one. So much gratitude to the many who championed the language guide and to IASLC for being a pioneer and taking that first step in shifting the focus from shame and blame to, compassion and non-judgmental language. And oh, there we go. And, I love this quote, do the best you can until you know better. Then when you know better, do better. And that's what we are trying to do here is educate people to know and do better, because the pain of watching someone you love suffer through the cruelty of lung cancer until their last breath is unbearable. So does it really matter whether or not they smoked? Does it mean that they deserve less empathy or that they deserve to die? Does it minimize the loss? Or do those left behind deserve less empathy? No, it doesn't matter. What matters are people. Using words that help, not hurt, matters. Empathic, guilt-free care and acceptance in the community matters. And what also matters greatly is that the lung cancer community stand united, one voice, and change the conversation. Only then can we educate others, kill the stigma, and save lives. Thank you.
Good morning, all. Thank you, Dr. Stiles. Esteemed colleagues, members of the press, thank you for the opportunity to present to you today and tell you a bit more about a review of interventions that are designed to reduce lung cancer stigma. As was mentioned, I'm Mr. Nathan Harrison, I need to correct as well, sorry, from Flinders University in Australia. Now, as Jill has so beautifully outlined as well, we know that stigma is a critical issue, but importantly, one that can be mitigated through evidence-based intervention. I'm delighted to be presenting this work on behalf of my colleagues in Australia. This project has been led by Ms. Julia Yamazaki and Dr. Kylie Morford from the University of Queensland and the NHMRC Centre for Research Excellence on Achieving the Tobacco Endgame. And this will build slightly on what Jill has mentioned as well, but in terms of actually conceptualizing this construct of stigma, stigma may first be internalized as self-blame or shame. For example, individuals living with lung cancer, conditions like COPD, and who have a history of smoking may internalize the idea that they are to solely blame for their disease or judge themselves as irresponsible, perhaps unworthy of sympathy. Or alternatively, stigma may also manifest as externalized devaluation in the form of discrimination or judgmental comments from others. We know that individuals affected by lung cancer and or other smoking-related respiratory diseases, such as chronic obstructive pulmonary disease or COPD, experience considerable stigma. So these conditions are the focus of our current study. This stigma is deeply rooted in the links with smoking behaviours, which perpetuates negative attitudes and misconceptions about those affected by these conditions. Now, for patients with these conditions, stigma is linked to poorer psychosocial outcomes, including distress and isolation. It can delay help seeking for initial diagnoses as well as subsequent health issues, and make patients concerned that their quality of care will be impacted. Evidence also suggests that lung cancer and COPD-related stigma may be increasing, particularly as denormalization strategies, for example, through mass media campaigns and anti-tobacco advertising, as well as smoking restrictions in society, have been used in tobacco control to discourage smoking amongst adults, as well as to discourage the uptake of smoking amongst younger people. Now, the ethics of smoking and stigmatizing people who smoke has been debated over time, particularly given that this strategy emphasizes individual rather than corporate responsibility for tobacco-related disease. Now, developing stigma-reducing interventions has been identified as a priority for the field, and evidence on the efficacy of such interventions is beginning to accumulate. In this study, we first aimed to systematically identify the existing stigma-reducing interventions that are out there in lung cancer and COPD, and secondly, to synthesize the components and reported efficacy of these interventions. Now, our systematic review was guided by standardized reporting guidelines, the preferred reporting items for systematic reviews and meta-analyses, and publicly registered on the Prospero database. Then, using lung cancer, COPD, and stigma-related terms, we searched 4 electronic databases for 425 initial non-duplicate records up to December 2022. We then screened through these in duplicate amongst members of the research team. Now, eligible intervention studies described an intervention designed to reduce either internalized or externalized stigma associated with lung cancer and or COPD. And we then assessed these studies using the JBI critical appraisal tools as appropriate for the various types of study designs. We included in this study case report, qualitative, quasi-experimental, as well as randomized control trial study designs. In terms of what we found across the existing literature, our team identified 10 existing studies describing 9 distinct interventions, which were then included in our narrative synthesis. Now, 8 of these 10 studies specifically concerned lung cancer stigma. Most of the interventions we identified were designed for symptomatic individuals or other high-risk groups in high-income countries. Most of the interventions yielded a statistically significant reduction in at least one measure of stigma or a decrease in stigma reported through qualitative methods. Most interventions were delivered in pilot or feasibility studies with comparatively small sample sizes or follow-up durations, and would therefore require further evaluation in trials. While studies generally showed a low risk of bias on the critical appraisal, no quantitative studies included control groups or multiple pre- and post-intervention assessments. This really highlights that there is a need for future evaluations in controlled trials, since it can otherwise be unclear whether the observed results are due to the stigma intervention component itself or a general result of healthcare access. We categorized the 9 distinct interventions we identified into 3 broad categories here. And it really shows that interventions typically provided information or instruction or reference material to individuals affected by respiratory disease stigma, which we deemed educational interventions, or perhaps guided behavior change, often via group programs in the behavioral interventions I've described here, or finally provided formal psychotherapeutic intervention, such as to improve mood, coping skills, and thought patterns. One intervention was directed on oncology care providers and 1 targeted family members and supporters, in addition to higher risk individuals. So across the studies included in this systematic review, most of the identified stigma-reducing interventions were aimed at reducing feelings of self-blame and shame, or implementing strategies to deal with stigma arising in interpersonal interactions. Most included interventions reported achieving reductions in stigma, with similar effects observed for remote and digital intervention delivery compared to traditional in-person and face-to-face modes, which does show promise in increasing accessibility for patients with comorbidities or loss of function related to respiratory disease. These findings also highlight that we need to further develop and evaluate stigma-reducing interventions in diverse socio-cultural contexts, and importantly, in partnership with those affected by smoking-related diseases. Amongst the interventions we've identified in the literature, there are no community or policy level interventions. Importantly, we also need to recognize that stigma can not only be addressed at the individual or clinical level. Combating this issue requires change in societal attitudes and an understanding of the role more broadly that the tobacco industry plays in continuing to sell a toxic and addictive product. Additionally, including validated stigma assessments in a wider variety of interventional studies could help identify more effective techniques for targeted stigma reduction. Thank you very much for the opportunity to share this with you today. Our poster is on display today and I'd be very happy to talk further. Thank you very much.
Thanks so much. The IASLC would certainly love to see a press piece on stigma, and certainly Nathan and Jill are available to all of you. Next, I'd like to introduce Dr. Solange Peters. She's going to speak about 6-year survival and health-related quality of life outcomes with first-line nivolumab plus ipilimumab in patients with metastatic non-small cell lung cancer from CheckMate 227. Remarkable that we're talking about 6-year survival and outcomes in patients with metastatic cancer. Dr. Peters almost needs no introduction, but she's the professor and chair of medical oncology and thoracic malignancies program in the Department of Oncology at the University Hospital of Lausanne, Switzerland. Expert in the field, she's authored over 500 peer-reviewed manuscripts, led numerous trials, and is the past president of ESMO. Dr. Peters.
Thanks so much, and thanks for staying despite the start of the sessions. So I was discussing with my neighbors. The main point is the 6 years, right? What I like to stress in this trial is this data have some very complementary added and additions in how we can analyze them and go into the depths of all the parameters which help us choosing the best treatment. But they have this very, I would say, special and specific feature of being the longest ever reporting of immunotherapy outcome in advanced non-small cell lung cancer, in metastatic non-small cell lung cancer. So it's quite good, and you'll see that for the community to be able to look ahead and try to anticipate what can be the real impact of these treatments, long-term speaking. So just I will be quite short, not to be too repetitive as compared to what you have seen before, but this is a trial which was the first one using this new combination of nivolumab and ipilimumab, 2 checkpoints. This is a large trial which basically was 2 trials in one. It was one trial doing the stratum of positive PD-L1 and the other one in negative PD-L1. As you can see on the right-hand side, the positive PD-L1 patients were randomized 1:1:1 to nivolumab, ipilimumab versus chemotherapy with an exploratory arm of nivolumab monotherapy. In the second stratum, which is negative PD-L1, a pretty large subgroup of negative PD-L1 patients, 550, nivo-ipi was compared to chemo with an exploratory arm of nivolumab and chemotherapy. This is quite important to stress that it's the first trial using nivo-ipi, but in parallel to lung cancer, nivo-ipi has been established across different tumor types over time, melanoma, renal cell carcinoma. So it was the very early days of these developments here. So basically in the CheckMate 227, there were many primary endpoints and secondary endpoints, but I'd like to focus today on the overall survival, of course, and the trial design was defining that the overall survival should be looked at in positive PD-L1. It was a knowledge of the time, but I'd like also to focus today on this new data, the overall survival by response and tumor burden reduction, as well as overall survival by baseline health-related quality of life. So these are the current curves at 6 years of nivo-ipi versus chemo in positive PD-L1, in negative PD-L1. In positive PD-L1, nivo-ipi has a hazard ratio of 0.78 against chemotherapy. And at 6 years, 22% of the patients treated with nivo-ipi are still alive versus, as you can see, 13% for chemotherapy. The experimental arm of nivolumab stands somehow in between with 15%. Remember that all of these patients have stopped the treatment at 2 years. Okay. In negative PD-L1, hazard ratio against chemo is 0.65. At 6 years, 16% are alive in nivo-EP, 5% in the chemo arm, and 10% is this exploratory nivo-chemo, quite classical intermediate arm. It's important also to look at progression-free survival. At 6 years, how many patients did not progress? 11% in nivo-EP versus 2% in the positive PD-L1, and 8% in the nivo-EP versus none at risk. So there were no patients to be available anymore in the chemotherapy arm in the negative PD-L1. So duration of response to end up with these important outcome parameters at 6 years. So 27% were still in response at 6 years on the nivo-EP, meaning that they were still benefiting from the treatment even stopped versus 4% the chemo in the positive PD-L1. In the negative PD-L1, it was 25. 1 out of 4 was still in response at 6 years versus none to be evaluable in the chemotherapy arm. The new, I would say, parameter, which are quite interesting also in the way we potentially not speak to the patient, but maybe anticipate the outcome of the patient. It's quite important for a clinician to have an idea about, or to try to predict as much as possible what can be the outcome of the patient. So in this analysis, you can see the waterfall plot to classify the disease according to the burden reduction, the magnitude of burden reduction. Of course, this is measuring the target lesions. So the magnitude of burden reduction is classified by 30 to 50%, 50 to 80, or more than 80%. Of course, these are target lesions based on the trial design. In the little purple stars, the purple stars are showing the real responses according to the RECIST criteria. And you will not be surprised that the vast majority with burden reduction are also in response. Maybe not all, but the very vast majority. So 2 conclusions when you look at the graph. First of all, the burden reduction, the number of patients who experience a lower, middle, and intermediate burden reduction. So the number of these patients is way higher in the nivo-EP as compared to chemotherapy. But what was the most striking for me in this analysis is each of this layer, each of this category of burden reduction is correlated with survival. In this patient population with more than 15% with more than 80% reduction, 67% are alive at 6 years. So really by the burden reduction, you can predict, and it is proportional, correlated, how long the patient will survive and the probability of surviving the disease. So that's very important. And that's something which for me indicates a bit to the clinician how those things are moving over time, helping to support treatment decision in the future. So all of these deeper responses were associated with long-term benefit. And it was, of course, regardless of the PD-L1 expression. So this is a graph in PD-L1 positive. I could have shown it's the same in PD-L1 negative. So additional analysis, we also have been looking at the health-related quality of life using the EQ5D. Remember, looking at all these parameters of anxiety, pain, all the self-care, normal activities, and so on. I missed one. So we have been looking at this health-related quality of life. It can be called a little intuitive, but basically what was interesting is if you score them using an analog visual scale, or if you score them using the TAF score, if you start with a good quality of life, your outcome will be significantly better using chemo or using ipi-nivo as compared to someone who is weaker, suffering more from the disease, starting with a lower quality of life. It might be a little intuitive, but sometimes it helps in making treatment decisions to know where you start from with the patients and in which condition he starts. So the safety profile in all of this trial remain unchanged since the 5th, 4th, 3rd year report of ipi-nivo. We have no unexpected toxicity, it's important to say. So this data represents the longest reported follow-up across all phase 3 trials in non-small cell lung cancer using immunotherapy. And the clinical benefit is further highlighted as an effective treatment, regardless of the level of PD-L1. And we all put an emphasis that it works very strongly and actively in negative PD-L1 patients. And I thank you for your attention.
Thanks, Dr. Peters, quite remarkable. And I think ties in nicely with the other comments on thinking about things from the patient perspective. Next, I'd like to introduce Janet Freeman Daly. Like all of our press briefings, we include an IASLC patient advocate to ensure that you hear how this research will impact patients. There's few better to explain that than Janet. She's a retired aerospace systems engineer, a freelance writer, and a metastatic lung cancer patient and activist. First diagnosed in 2011, Janet's focus really has been on translating the experience and science of lung cancer for others, and particularly for patients. She serves as a research advocate for thoracic oncology research programs at 2 NCCN facilities, various government agencies, and clinical trials. She's collaborated on research and education projects with lung cancer nonprofits, published research papers and science articles, co-founded the lung cancer social media group on Twitter, which really brought information, I think, to a lot of patients and brought patients and professionals together. It really sort of erased that divide between the two groups, or at least started to erase it, I guess Janet would say. She also co-founded the Ross Wonders patient group, LCFA's Hope with Answers, and IASLC Stars to help educate our lung cancer advocates. She blogs on greatconnections.net. Janet, can't wait to hear your thoughts.
Thanks for staying till the end. So the presentations we heard today address several areas that are really important to patients. Obviously, one of them is treatment. We always like to hear about treatment options that allow us to live longer, especially if you get to stop treatment. But it's also important to have treatment options that, while they don't allow us to live as long as others, that they still allow us to be around for things that are important, especially for those patients who have difficult to treat lung cancers or that don't have many good treatment options yet, like KRAS, small cell lung cancer, and mesothelioma. But there are other things that are in here too. Lung cancer diagnosis and treatment can be very invasive and take over your life. And to have that all happen and then have the treatment not work is incredibly disappointing and has a huge impact on the patients and their families. So being able to find biomarkers that, one, help you determine which treatment is more likely to work, and two, are non-invasive, is huge. It's also important that we find effective ways to help patients deal with the stigma. And Jill, as a patient, has explained it really well, but I've experienced it myself. It's amazing how easily it comes up. My very first breakfast conversation here at this conference, when one of the people at the next table found out I had lung cancers, but, oh, you're a smoker. It's everywhere. And it doesn't matter. The patient should be able to get treatment regardless of what their background is. Hopefully some of these things will help both with patients hearing themselves treated as people in research and in being cared for by their doctors. For some of the specific sessions or presentations that we heard, it's really important to find treatments that help us live longer and even allow us to dare to hope for a cure when you have metastatic lung cancer. So the study on Nivo and Ipi is really amazing that there are patients that are still out there. Obviously, we need more treatment options because not everybody is there, but we're getting there. It's also important to realize that just increasing the overall survival is not the only thing that's important to patients. The study for small cell lung cancer did give us longer overall survival. It's not as big of a survival gap as some of the other treatments. And it's not just overall survival that's important. Quality of life is important too. And it needs to be the patient who makes the decision about which one matters most. If somebody just wants to live long enough to see their child get married, living for a few more months, even if you're not particularly comfortable, may be worth it. For someone else, living a few more months, if they're miserable, might not be worth it. And you need to ask the patient and get their opinion on what's important to them. Being able to find which of these treatments is going to make a big difference and has the best chance of being a good treatment is also huge. And while those of us with oncogene-driven lung cancers do have a biomarker that allows us to know which treatments are likely to work, there's a large percentage of lung cancer patients who don't have that. Anything we can find that helps move that needle is wonderful. and a breath test that doesn't require getting a needle stuck in your arm or getting cut open is a wonderful option. So I'm very happy to see that that's coming along. Quantifying stigma is really important. Jill and the other presenters, sorry, I'm horrible with names, did a really good job of talking about that. And I think we're just now starting to see the research quantified as to what interventions make a difference for patients and what providers and researchers can do to change their language to help patients feel better. But as stated in one of the research pieces, there were no community or policy interventions available yet. So we have a ways to go, but we're actually moving into research instead of just thinking about what works and what doesn't. And all of these things that were mentioned today can make a big difference for patients. And I really appreciate the researchers' work. Thank you.
Well, we're just over on time, and I know that there's not a lot of people left in the room, but I know hopefully there's a lot online. It's important that this recording will be sent out to the press as well. But are there any pressing questions? Yes, Chris.
Can you hear me? We do have a couple. For Dr. Gadgeel, I'll summarize the question for you. In your opinion, what can be done to extend overall survival among the patient cohort that you've studied here?
I hope that the person who asked the question could tell me actually, but what I would say is that I think that as we are getting this long-term follow-up, I think we'll get a better understanding of which of these patients benefit from these direct G12C inhibitors. And as we learn more about the patients who do benefit and the patients who don't benefit with this long-term follow-up, we'll be better able to characterize the tumor types of these patients, and based on that understanding, develop novel combinations or even novel drugs that will provide that long-term benefit.
We have one for the entire panel because unfortunately Dr. Cheng had to leave, but opened to all the clinicians and patient advocates a question about the Benmelstobar data. Specifically, how does this data compare to what we've seen with Pembro or Nivo in small cell lung cancer? I know it's a fairly novel treatment, so anybody that wants to take it, feel free.
Dr. Peters.
You will complete, Shirish. It's, well, not really, I would say Nivo and Pembro, because they are the two drugs which failed in small cell lung cancer. So I would say atezolizumab and durvalumab, which are the drugs which are now changing the game in small cell lung cancer. But they very modestly changed the game, right? With an improvement in 2 months of survival. They have changed the paradigm of frontline treatment of small cell lung cancer when combined with chemotherapy and continued for a long period of time. So these data, of course, it's a trial done in a certain environment with drugs that honestly we don't really know. There is one which is a multiple target TKI. The other one is, as far as I understood, a biosimilar drug of an anti-PD-1. We really don't handle this drug usually, so we are not familiar to them. But the magnitude of the benefit being seen here is way more impressive than what we have been seeing with atezolizumab or durvalumab. To which extent it is applicable, it is reproducible, it would stay the same in a global trial with all the real world circumstances of a global trial. It's not about only ethnicity, it's how patients are handled all around the world. I don't know, but these data, at least for me, make me very curious about extending the efforts, trying to confirm that such a magnitude of benefit can really be observed. So survival benefit is 2 or 3 times what I would expect from a mono checkpoint.
Oh, go ahead.
No, go ahead.
Yeah, and as a patient advocate and someone who's, my mom died of small cell lung cancer, I want to reiterate what Janet said in that this is, situations like this, overall survival is not the only important endpoint to patients. And truly, the most important conversations clinicians have with patients aren't the data-driven ones. They're the relational ones, asking patients and families, what's important and meaningful to you besides living longer? What trade-offs are you willing to make? So that is, yes, 2 months may, whatever that means to researchers and whatever that means to clinicians is quite different than what that means to patients. And so it is absolutely critical to take the data and apply it in the context of the patient and the family in front of you. And so I just wanted to emphasize what Janet said about that.
I just had a very small point after what Dr. Peters and Jill mentioned. In small cell lung cancer, clearly there's a concern about CNS metastases. So I don't think that was presented. Maybe it's in the full presentation. It'd be interesting to know what the difference in terms of CNS relapse was between the two groups. So definitely interesting data that probably needs to be followed up.
Question for Kevin. Just in your opinion, how far off is a consumer or professional-based test or assay available for using breath in an effective manner to diagnose mesothelioma?
For the diagnosis, we are currently running a last phase of clinical utility. So if that works out, it could be very fast. But also for lung cancer, a lot of efforts going on, a lot of talks here also at the meeting, at the conference. So I'm guessing you will see the first ones coming up. There are some now, but the first real usable ones maybe in 5 years or so. So.
And do you envision those as being partners to imaging, I assume, or independent from imaging?
They will have go hand in hand. I don't think they will be independently. So one will need the other.
One more question for Dr. Peters. Initially, the side effects of EPO made it hard to use. Has that been overcome with more experience? I can repeat
Dr.
that.
Peters.
Sorry.
Solange, Chris has a question for you.
All right.
Sorry,
We were just talking about.
I'll repeat that. I'm sorry.
Sorry.
Initially, the side effects of IPI made it hard to use. Has that been overcome with more experience, in your opinion?
It's a very good question. I remember the old days because for me, 6 years is really 6 years because we treated patients from the first day. I remember at that time we had a hotline for the doctors who had questions or the family doctors who wanted to know if something is severe or not, because it was kind of a discovery process. We were telling the patient it can give rise to any kind of side effect. Anything abnormal, call us. So it was, and now we've been learning the panel of side effects, the timing of the side effects, and how to treat them. So still, ipilimumab has toxicities, that's for sure. But to arrange a magnitude, but also a type of side effects that we absolutely know how to manage, and without wanting to be academically focused, also in community oncologist setting, they perfectly know how to handle that. So I think you should never minimize the symptoms and the toxicities that the patient reports, because that's the only mistake which can lead to severe outcomes and severe, I would say, events. But the toxicity profile is highly manageable. I've been giving way more toxic drug in the field of lung cancer, I can tell you, in the past than ipi/nivo. So usually it's really something which can be managed. And still keep in mind, I don't know if it's really a good message, but handling side effects of IO is also a very important step forward, knowing that these side effects are usually correlated with an immune response. So it means that at least what you're doing is acting in the patient the way you want it to act. So it's not pure poison. It's also about what you aim to do.
Other questions? Thank you for staying on, panelists.
Thank you.
Thanks, everybody.
Thank you.